Hello, dear colleagues. Welcome to our session today. My voice is clear. Thank you. We will start soon. So today's volunteer active participant is Dr. Sarwat. Is she around? Okay, any volunteer to perform if Dr. Sarwat is not around? Yes, doctor.
Thank you, sir. Thank you.
You are welcome. What is your good name? Dr. Yasman?
Sir, yes, sir. Yashwant.
Okay, Dr. Yasman. Okay. This is your case, and we will start in 5 minutes time.
Sure, sir. Thank you.
Prepare for it. Okay.
So shall I start? Hello.
Yes, Dr. Yashwant, you can start now.
Yes, sir. Hi, my name is Yash, one of the doctors in the clinic today. Are you Miss Laura, 38-year-old?
Yes, Doctor, I'm Lara. I'm 38 years old.
Hello, Laura. I'm here to discuss regarding your health condition, examining you and address your concerns. Is that okay?
Yeah, sure.
Okay, Miss Laura, I understand that you have been having some issues with your weight. Is that correct?
Yes, doctor, actually, it is not the weight only, but also my blood pressure and some other complaints also that I want to tell you. Basically, uh, I have been diagnosed as a case of high blood pressure for now almost 2 years. And
Okay.
for 2 years ago, uh, I was having like a high blood pressure, and together with this, I was having sometimes headache. With this headache, uh, I was just went to my GP. So he found that my blood pressure is high. So initially, he advised me to do the lifestyle modification, and I followed his advices. He advised me to uh, do the daily exercises and daily walk. With that, he advised certain diets also for me. So I followed the dietary plan also, but my blood pressure remained high. Okay.
Okay.
Uh, 1 year ago, he started some medicine for high blood pressure. He told that only the lifestyle modification is not working. So this
Okay.
is the time to start your blood pressure medications. So I started the blood pressure medications, but still my blood pressure is not controlled. So he changed to another medicine, then he changed to another medicine, but still the blood pressure is not under control. And together with this, I noticed that I'm gaining weight also, and I feel tired and headache off and on.
Okay. I appreciate your knowledge regarding your health condition, Laura, and we'll try to address as get to the bottom of the condition. So let me just discuss one by one. Like, how long have you noticed that you had been gaining some weight?
It is almost now, doctor, 2 years, almost 2 years now.
Okay. And had you found any changes in your diet that you have done which can be contributing to this?
No, I try to have a low calorie diet, and I try to avoid the carbs in my diet. Even then, my body weight remain on a higher side.
Okay. So had anybody said that you have been snoring a lot rather than before in your sleep?
Yes, I do snow, doctor.
Okay. So how do you feel any tiredness? You said that it is more in the morning or in the evenings.
Tiredness is mostly in the afternoon or in the evening time, doctor.
Okay. So do you feel fresh when you wake up in the morning?
Yeah, most of the time I feel fresh.
Okay. And do you think you had a very good sleep every night, or do you think there is a disturbance in your sleep pattern?
Mostly my sleep is okay, doctor.
Okay. Any breathing difficulty have you noticed?
No,
Okay. And any pain in your hands or any tingling or any numbing sensation have you noticed in your hands?
no tingling sensation, but I feel sometimes the cramps in my legs, doctor. especially the legs.
Okay, so can you exactly point to me out where exactly it is? It is in the upper part and the lower part?
Yeah, it is in the calf area and in the upper thigh area also.
Okay, and is it in the both of your legs?
Yeah, both of my legs.
Okay, and for how long are you having these cramps?
Almost now, Doctor, 1 year it is more. And
Okay.
whenever I do activities, I do some work. After that, I feel
Mhm.
that I'm having some crampy type of feeling in my muscles.
Okay, I'm so sorry to hear that. And anything that you do that makes it better? Like, have you tried any therapies for that, which gave you some relief?
No, doctor, I just try to hydrate myself and you can say I want to just take some uh, salty things so it gets better. And with the rest, it gets better.
Okay, so can you say that do you have any salt cravings as well then?
No,
Okay, but you tried some salty things that which can you felt something better, right?
yes, yes. Just like a sports drink, the sports people are taking.
Okay, and do you have regarding your headache, like do you had any specific part that is paining with your headache?
No, no, there is no specific part, doctor. It is just like sometime on at the back of my skull, and sometime I
Mm-hmm.
feel like it is at the front of my head, and sometime mostly like this,
Okay,
it is at the back and the front of my head.
right, right. Can you name me the medication that you have been taking? Like, do you have any idea regarding the medication that have been prescribed?
Yeah, initially the doctor she is showing to you the medication list. She was started on lisinopril, and then amlodipine was added. Okay, she was
Okay,
receiving lisinopril 10 milligram, then started with amlodipine 5 milligram. That it is increased to 10 milligram also. And these two medicine mainly she is taking, and sometime in the recent past another medicine added, that is thiazide diuretics.
okay. Thank you. Any other medical condition that you have that you have to be aware of?
No, doctor.
Any similar complaints? Have you noticed any similar conditions in your family?
Um, I don't know, but my father is having high blood pressure, and he had like a stroke also when he was 55 years old.
Okay, I'm so sorry to hear that. That your father had any known diagnosis that he was given?
They told you have the high blood pressure, and he used to take the medicine for high blood pressure, but I don't know exactly the diagnosis, doctor.
Okay, and I'm gonna ask you some personal questions if that's okay with you. Like, do you smoke, Lara?
I was smoking, doctor, before 2 years.
Right.
Then I stopped the smoking as my GP suggested, as the blood pressure was creating problem. So I stopped smoking.
Oh, that's good. And do you consume alcohol?
Only over the weekend, 1 to 2 units.
Okay. And what do you do for living, Miss Laura?
I'm a secretary in an office, doctor, and together with this, I was taking part in the sports. I was doing the cycling. I
Okay. And
stopped
how is it
cycling like
affecting?
3 years ago. I stopped cycling, but sometime I do also for my fitness.
Okay. And how is it affecting like these things? How it is affecting your daily life?
Yes, of course, doctor. Having headache and the high blood pressure and sometimes the muscle cramps, they prevent me from my daily activities, especially after coming from the office. It is difficult to manage the things.
Okay. Any rise in your body temperature have you noticed?
No,
Any lumps and bumps?
no,
Any skin changes or rashes have you noticed in your body?
no,
Any dryness of your eyes or mouth have you noticed, Laura?
no.
Okay. Thank you, Laura. I'm going to examine if that's okay with you. I'm going to start by having a look at your hands and see if there is any wasting sensation in your hands or any clubbing.
No.
And I would like to go for eyes and check for pallor and jaundice.
You would like to know the blood pressure?
Yes, I would like to know the blood pressure as well.
Blood pressure is 160 over 100, and
O-
heart rate is 90 beats per minute regular.
Okay. Is there any postural drop?
No.
Okay, and I would like to check for the visual fields if there is any problems in your vision.
Visual fields are okay. Visual acuity
And I
is
would like,
normal. And
okay,
also the confrontation method, you are checking the visual field, it's okay. And also the edge movement of the eyeball, it's okay.
thank you. And I would like to offer the check for BMI at this point.
PMI is 28.
Okay, and I would like to check for neck circumference.
Neck circumference is 16 inches.
Okay, and I would like to have a look at her mouth and see if there is any decreased airway space.
No, it's okay.
Okay, and I would like to examine her heart sounds and look if there is any murmur.
No murmur.
I would
A
like to
normal
check
heart
for
sounds. S1, S2, not audible. Yes.
okay. I would like to check for renal bruit
Okay. No renal bruit.
and is there any edema on her legs? I would like to press and see if there is any edema.
Legs are bulky. On both legs are bulky, but there is no
Okay.
pedal edema.
Okay. Any rashes on her tummy or any rashes on her legs?
No.
Okay. And I would like to just auscultate the base of the lungs just to see if there is any uh, crepitations. Fine.
No crepitations.
Okay. Miss Laura, thank you for examining, cooperating for examination. Like, do you have any
You still
concerns, Miss
have
Laura?
you still have 3 minutes and 4 minutes you have still have it.
Oh, okay, sir. Okay, sir. I thought it was just 2 minutes. Okay.
Yeah.
So, uh, sir, then I would like to
In the
examine
history, you
for
want to
the.
ask something, or in the
Uh,
examination, you want to do some more examination.
sir, I would like to assess for tone at this point and see if there is
Mhm.
any power, any tone and power to the upper limbs and lower limbs.
Yeah, you can say the proximal muscles are weaker
Okay,
in the upper limb
and
also and lower limb also.
okay,
Tone is
and
normal. Tone is
okay,
normal.
okay, sir. And are you married, Miss Laura?
Yes, doctor, I'm married.
Okay. Sorry to ask, by any chance, do you have any casual partners?
No, doctor, I'm living with my
Okay.
husband.
Right. And do you have any increased thirst or increased hunger have you noticed recently?
You know, my appetite is good, doctor, not increased, not decreased.
Okay. Any weight changes have you sorry, I meant to ask any decrease in your any one of the water works?
No 2 minutes remaining. Water work
Okay.
is okay. Water work is okay.
And how is your and do you have any hard stools or any loose stools?
My bowel habits are regular, doctor.
Okay. And any cough or any phlegm have you noticed?
No. But I feel sometime,
Okay.
doctor, my heart is beating fast. I'm having heart racing and pacing.
Okay. And do you have any particular time of this have you noticed?
It is just like when I develop this muscle cramps. At the same time,
Mhm.
sometime I develop the heart racing also.
Okay. Miss Laura, do you have any concerns at this point?
Yes, doctor, what is wrong with me?
So, Miss Laura, I think you have a condition called Cons syndrome. It can be due to the underlying cause of your high blood pressure.
Hmm.
It can also reflective of your some of your investigations, but we would like to do some more tests to confirm the diagnosis, Laura.
So my blood pressure is because of this, or blood pressure is leading to this disease?
So the disease can be leading to this high blood pressure and also this
Mm-hmm.
weakness and tiredness you are feeling. At
Mm-hmm.
we would like to do some more tests which can also rule out other conditions as well. There are some other possibilities running through my mind at this moment. There can be other hormonal issues as well, but it's very early to say unless and we
Okay.
do some investigations, Laura.
What is the possible cause if I'm having this syndrome, what you told?
So it can be due to a problem in your gland which sits on the top of your kidneys called adrenal.
Mm-hmm.
So it can be due to the hyperactivity of that gland.
Mm-hmm.
So we are going to do some imaging and see what is the status of the gland.
Okay, so will I need some surgery to control this problem because my blood pressure is not being controlled by the medicine?
So your concern is valid, Laura. So at this point, I think it's very early to say comment on anything. Maybe we will just run through some tests, and we will keep you under follow up, and we will gonna involve some specialist if at all if it is required. We'll definitely, Laura.
Uh-huh. Okay. So will you admit me today, or what you will do for me today, doctor?
So we are gonna keep you for some tests meanwhile, and when the reports come back, we will let you know because we have some problem with your awareness of your heartbeat as well. So we're gonna do some basic investigations that include a chest tracing of your heart, and
Mhm.
we'll keep you under observation for a while and see if there is anything that needs your admission. Otherwise, you can be good to go, Lara.
Okay. Thank you. Time is up.
Thank you.
Summarize your case.
Sir, I have a 38-year-old female who came with weight gain, tiredness, headaches, and negligent blood pressure from the past 2 years. And
Mm.
she has been tried on different medications, and recently she's been shifted on the thiazide diuretics. So on examination, um, she was having some proximal weakness and some increase in neck circumference and some increased BMI as well and increased blood pressure and other than that there is some puffiness in her legs. I don't have any other relevant findings to present at this point.
Mhm. Okay. And what do you think? What could be the cause, possible cause?
So it's can be due to first differential would be primary hyperaldosteronism can be cons considering the investigations and the hypertension. I would like to also rule out central causes as well because the patient is also complaining of headache and also some proximal myopathy. So I would like to rule out any pituitary conditions like Cushing's or any
Mhm.
pituitary causes as well.
Okay. So make a differential diagnosis list. Can you make a differential diagnosis list?
So based upon the history and diagnosis, examination, my first differential would be cons. Second would be to rule out Cushing's, and third would be to rule out obstructive sleep apnea as well because she has some difficulty in snoring and sleeping. So
Okay. How you will investigate this patient?
uh, I would like to start by assessing her hormonal profile. Specific investigations would include pituitary function tests and also electro baseline serum, sodium electrolytes, calcium, magnesium, and I would like to also rule out uh, any arrhythmia by doing a heart ECG because the patient is having some hypokalemia. And I would like to also do some thyroid function test to rule out thyroid disease. And I would like to do out a specific test like renin aldosterone ratio to confirm the Con syndrome. Mm, and I would like to do a imaging to rule out for any localized causes depending upon the secretion of the
Okay.
pituitary. Like it is, if it is a low dose dexamethasone test, I would like to go for high dose dexamethasone test, and depending upon that, I might be doing an MRI brain or MRI of the abdomen.
Why to do low dose dexamethasone and why to do high dose dexamethasone?
So it's very early to comment on this. Depending upon the response of the patient, I would like to rule out Cushing's. So I would definitely go for low dose dexamethasone suppression test first, and to see if I can get any changes on the cortisol level after doing definitely fasting salivary cortisol in the first place.
Right. Okay. If your patient is having like Cohen syndrome, what are the specific investigation for that?
So specific investigations would be to do CT or MRI of the abdomen and renin angiotensin aldosterone ratio
Hmm.
and high potassium to look for potassium and to look for sodium as well, and to look at if at all if there is a retinal bruit, I would like to also consider a retinal Doppler as well.
Okay. Okay. Any specific test or gold standard test for Cohen syndrome?
Uh, Sorry, sir,
Okay.
not I could think of right
No,
now.
no, no problem. No problem. We will discuss later on. So how you will manage this patient if the patient is having Cohen syndrome?
So the management depends upon the patient whether he's having hyperplasia or a adenoma. If at all, if the patient is having bilateral adrenal hyperplasia, the patient might be kept under medical management. They could be, if at all, if the patient is having unilateral, depending upon the size, we can go for surgical management.
What will be your multidisciplinary team?
So my multidisciplinary team would be including endocrinologist and including the surgeon, and I also want to keep in the specialist nurses, which would work around the dietitian for sure, with increase the restriction of some foods as well, and
Okay.
uh, yes.
What will be the non-pharmacological management in this patient?
So the non-pharmacological would be modifying diet and exercise,
Yeah.
and also encouraging the patient to
What
diet and
what dietary advices you would like to give to her?
so the dietary advices, I would like to increase the salt intake if at all possible, and sorry, no, and mm,
Yeah, no problem.
for to increase
Okay.
to not to go for any excessive exercise at this point. Don't do any
Hmm.
rigorous physical activity,
Hmm.
and yeah, that's it, sir.
Okay.
I couldn't
Last
get that.
question. What will be the medical treatment? What antihypertensive you would like to use in this patient?
So I would like to use a aldosterone antagonist. It can be the potassium sparing, especially. So it could be eplerenone or spironolactone.
Okay, good. Time is up, but I would like to just continue discussion with you. Then I will discuss with you the possible things here. So, do you think this is primary hypertension or secondary hypertension?
Sir, there is a family history and early hypertension, stroke in his father. So I'm not sure, but it can be due to definitely secondary depending upon the investigations and history.
Yeah. But as you're thinking about the Cohen syndrome, okay, and what
Yes,
is the age of the patient?
38-year-old.
So, when the primary hypertension is usually starts?
Sir, after 45, 40.
After 40.
Yes.
So, it is not primary or essential hypertension. It is secondary
Mm.
hypertension.
Sir, I would only
Okay.
consider secondary at this point. Yeah,
Yeah, because she was diagnosed as hypertension before 2 years when she was 36 years old.
true, sir.
So, what could be the secondary hypertensive causes? How you will classify?
So secondary hypertensive causes or in general regarding the respect of the gender, it could be due to the prostate. It could be due to the pheochromocytoma. It could be due to cons,
Mhm.
and uh,
Okay.
It could be due
Okay,
to
no problem.
Cushing, could be
Yeah,
due to thyroid
good.
disorders as well.
Yes. Anything else? Some drugs?
Yes, sir. Drug induced is a thing. I'm not really sure which drugs can cause at this point. So,
Okay, good. And what about, do you know some connective tissue disorders leading to hypertension?
connective tissue disorders leading to hypertension or can be scleroderma, systemic
Yes,
sclerosis,
yes,
and SLE itself can also cause hypertension depending upon the renal involvement,
yes.
and rheumatoid arthritis as well.
And mixed connective tissue disorders.
Yes, mixed connective tissue disorders.
Pregnancy can lead to hypertension.
Yes, sir. Pregnancy can also lead to hypertension.
Okay,
Any illicit drugs
okay.
can also lead to hypertension. So,
Like what?
cocaine and MDMA, amphetamines.
Yeah. Good performance, Dr. Yes. It is still like there are something that you have to improve in the history and in the examination and in your presentation also. So in the history there was missing, like you did not ask about the detailed history about the headache also. Whenever we have any pain or headache, we have to use the mnemonic known as what? Socrates.
Like Socrates, yes, sir.
Okay, site of the headache you asked. Okay,
Yes, sir.
onset you did not ask, character you did not ask, radiation you did not ask, aggravating factor, relieving factor you did not ask. And since the time the headache started, it is getting worse or it is improving or it is same, you did not ask. Okay, and
Okay, sir. Yes.
associated symptoms you did not ask. Severity is on the scale of 1 to 10 you did not ask, right?
Yes, sir. Yes, sir.
And yeah, so these are the things that you have to improve in the history. And but don't be like feel any shy or any low mood. This is the process of learning that you have to learn slowly and gradually. So this was the good attempt. Moreover, about when I told you about the sometime the heart racing is pacing is there. So what further question you can ask?
Chest pain and any sweating
Very good,
associated with it. And can you tap
very
and
good.
show me
Yeah,
how the
regular
reason?
or irregular, regular or
Regular, yeah.
irregular. Okay,
Yeah.
good. Right. Okay. So when the headache is there, did you check the blood pressure at the same time you have the high blood pressure or no? Okay.
Uh, yes, sir.
So you
Sure.
have
Yeah.
to correlate whether the patient is having headache at the same time the blood pressure is high or no. This is one. When you have the headache, do you feel like you are having the anxiety or panic attacks also? Did you lose the temper? Okay. Is this headache coming during the stressful conditions? These are the questions. And did you notice that
Okay.
when you are having the headache, you have sweating also? Okay.
Yeah.
The
Okay.
sweating there or no? So these are the questions that you want to rule out the pheochromocytoma. This scenario is indicating something because in this scenario, the sodium is written and potassium is written also. But in some scenario, they are just not mentioning the electrolyte. Okay. They might be
Yes, sir.
just giving you the findings of high blood pressure. Then it will be like in open scenario, then you have to ask many questions. Okay. But here there is a hint, so you reach the diagnosis, I think, easily. But in some 20% of the cases, the potassium level will be normal. Okay. So if the potassium is normal and the sodium is here, the upper limit is 146 and the patient is having 147. So sometime it is not easy to reach to the diagnosis from the scenario. And this scenario is just giving you a hint. Okay. So these are the important points. Okay. And then she told you that there is weight gain. How much weight gain over how much period of time? What about the appetite? You ask about that. And Is it generalized weight gain, or it is in some specific areas you are having the weight gain? So these are the important questions that you have to ask. Fatigue, you ask about the tiredness, what time of the day you are having the tiredness. Okay. So these are the different presenting complaints of this patient. In the past medical history, you ask about the any long-standing disease other than the high blood pressure, and you ask about the medication history, but you did not ask about over-the-counter medicines, and you did not ask about when you have the headache, do you take any painkiller or no? Okay, and do you use any party
Okay, sir.
drugs? That also you did not ask. Okay, any allergies in the with the medicine or no? This is also important question in the drug history. Okay,
Yes, sir. I
and
understood, sir.
yeah, then the blood
Sir,
pressure. Yes.
yes, sir. Please continue. Sorry.
And the blood pressure, what about the record of the blood pressure? Do you have the record of the blood pressure or no? So these are the questions.
Okay, sir.
Then uh, proceeding from there, the family history you asked, and the personal history, you took the good personal history, like you asked about the smoking, alcohol, job, and impact. And then whom do you live with? She's living with the husband. So after that, the casual partner is should not be asked here. It was not making
Okay.
any sense to ask about the casual part because the scenario is not related to infections, isn't it? So
Yes, sir.
whom do you live with? So I'm living with my husband. How is your intimate relationship? If you want to ask, so intimate relationship is good. Then in the female,
Okay,
we
sir.
have to ask about the menstrual histories
Ministerial
with the
history. Yeah.
yeah that was missing. Okay, what about
Yes.
your periods? What about your periods? Are they regular or irregular? What about the flow? Did you notice any changes in the menstrual period during last 2 years? Okay. Do you take the pills, OCPs? Okay. Any plan of the pregnancy? Okay. And do you have kids? What about your pregnancy? If she says yes, I have the kid. So when was the last pregnancy? Was there any serious thing happened during the pregnancy? Did you develop high blood pressure during the pregnancy or no? Okay, so these are the important points. So the it is mnemonic for this one is the P4. You can say the partner you are asking whom do you live with, and the pills and the pregnancy. By any chance you are pregnant, and do you have kids? Okay, when was the last pregnancy? Was it having any uh, complications or any events, significant events happened during the pregnancy or after the during the delivery or after the delivery? Okay, so you want to ask about the pregnancy complications and also the postpartum period. Okay, if she is using the pills, we have to stop the pills here, oral contraceptive pills, because the blood pressure is high. So
Contribute. Yeah.
OCPs are contraindicated here. Clear?
Yes, sir. So can I ask a question?
Yeah.
So, sir, if at all, if there is no history of hypertension, just it has been given the patient came with weight gain. So, because when I started this case, I was just assuming what can be the potential differences of the weight gain. So, my
Mm.
history was kind of focused on around weight gain. So, I think I have missed so many history which could have ruled out secondary causes of hypertension like pregnancy and pheochromocytoma, all this stuff. So,
Yes.
is it like uh really how should we cater the history like in this kind of cases? Because I was thinking more in terms of weight gain and I was thinking differentials in terms of weight. What could be the
Mm.
possible causes of the weight gain? I
Mm.
was highlighting the history according to that. So I must have omitted some things because of that. So how did we judge like at this point, like which should we ask and which should we not ask?
Yeah. So I will give you the brief, like the points that we have to consider. The first thing is we have to know what the patient is complaining of. Okay. We have to take the complaints from there, the patients. Like in this, what were the complaints the patient was having?
Uh, Sir, mainly it's weight gain and hypertension.
Yeah. So the weight gain, the differential diagnosis of weight gain. When you have a patient with weight gain, you should have some differential diagnosis in your mind from outside. Can you give me the
Yes,
causes
sir.
of weight gain?
Sir, I was thinking mostly endocrine causes could be Cushing's and
Yes.
Cushing could be thyroid hypothyroidism and
Yes.
could be other abdominal causes which I'm thinking which are very rare, but ascites and stuff can cause weight gain, CLD, and these are the systems which I was mostly thinking of, endocrine and abdomen, because other than that, CNS, CVS, and RESP, I couldn't find any particular causes which can lead to weight gain.
Okay. So for the weight gain, there is mnemonic of mine that is known as champion.
Okay, sir.
Okay. Champion. I will write in the chat.
Okay.
CHAMPION. Okay. For this, you have to remember this: Cushing syndrome 1, hypothyroidism 2nd, acromegaly, metabolic syndrome,
Acromegaly.
polycystic
Yeah.
ovarian syndrome. Okay.
Mm.
And insulinoma, simple obesity, acidoblastosis. These are the
Okay, sir.
differential diagnosis. So when you have a patient with weight gain, you should try to rule out first these things. Okay. Cushing syndrome, you have to think, and the Cone syndrome also you can keep here, but the Cushing syndrome first. So first you will ask after this weight gain, you started the few question about the weight gain, you will do the targeted question related to the Cushing syndrome. Okay. What will be the questions? So I will give you some questions. So I will ask to the patient, you have the weight gain. Yes, I have the weight gain. So how much weight gain over how much period of time? Yes, doctor, I got like 5 kg over in last 2 months or 3 months or 5 months period of time. What about your appetite? Appetite is good. Okay. So could you please tell me where is the weight distribution? Is it some specific part of your body or it is all over the body? If the patient is
Right.
telling you, yes, I'm having more on my upper part of my back and my tummy area, okay, so it is going in favor of Cushing syndrome. Okay. If the
Yeah.
patient is telling it is more in my hands, in my in my hands and the feet, so it is going towards the acromegaly. If it is generalized, then
Acromegaly.
we have to think about the hypothyroidism. Okay.
Hypothyroidism.
Then further question related to Cushing syndrome, you will ask certain question. Did you notice you have some hair growth on your face or on your face? Do you feel your skin is oily? Did you feel that your skin is bruising easily? Do you notice that your skin is changing, like it is becoming thin or no? So these are the specific questions related to two, three questions you will ask about every disease, and then you will find some disease. So you will ask some more question about that. Okay. So these are the question related to the Cushing syndrome. If she says you
Questions.
want yes, 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 so it means it is going in favor of Cushing syndrome. If no, then you will ask the hypothyroidism question. Okay, you have generalized weight gain. Okay, tell me what about the weather preferences? Do you have any weather preferences? Okay, what about your skin? Skin is becoming dry. Yes. And what about your bowel habits? Do you have any constipation and a hard stool or no? If she says yes, 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 so it is going in favor of going in favor of hypothyroidism. Then ask about the menstrual history of this patient. So in hypothyroidism, there will be heavy menses. Okay, you will reach to the point. Then the acromegaly. Okay, so acromegaly, the patient will tell you, no, it is just like in my hands or in the feet. Did you notice changes in the size of your shoes? Did you notice the ring size is increasing? Did you notice that your facial appearance is changing? So these are the questions. Then you will ask a specific question. Okay, like do you snore and do you have headache? Which part of the head you have the headache? Okay, is it moving anywhere? What about the visual problems? So these are the questions will be according to the acromegaly. Metabolic syndrome, do you have any long-standing disease like high blood pressure, high blood sugar? Yeah. Okay. And the cholesterol level, if it is metabolic syndrome given in the scenario, so patient will give you history in the long standing that my cholesterol is also high and my uric acid is also high. Okay. Polycystic ovarian syndrome, the patient will be giving you history of like weight gain. Together with this, patient will be having the excessive hair growth. Excessive hair growth will be in two conditions: Cushing syndrome and polycystic ovarian syndrome. Okay. So then you
Okay,
will
sir.
ask the further question: do you have any menstrual irregularities? In polycystic ovarian syndrome, patient will be having oligomenorrhea. So she will give you the
Polygon.
irregular menses. Okay, like this. So uh, the point is, she will give you two, three uh, presenting complaints. You have to pick up the one that can give you the good diagnosis that can help you to reach to the diagnosis. Okay, so if you don't have the idea, then you have to just like you have to see which area the symptom is there. Okay. For example, headache. Where is the headache? Headache is in the head. So ask the question related to the head, everything. Okay. If the patient is telling you, I am having the fatigue, fatigue is generalized. Okay. So then the approach for the fatigue is what time of the day you feel you have the tiredness. Is it in the morning? Was it in the evening? If it is in the evening, it is going in favor of myasthenia gravis.
Nice.
Yeah. Okay. If it is early morning or all over the day, so there are many causes for that.
Yeah.
Okay. So with the practice, with the things, it will be improving. Okay.
Yeah. Thank you, sir.
Welcome. So I would like to just summarize this case. Okay. Today uh, we have like a short session of 1 hour. So I would like to just summarize the case, and we'll see whatever we can do. I have 5 to 10 minutes more. Okay. So first thing is I want to give the causes for secondary hypertension. Whenever the patient is having hypertension less than the 40 years of age, we should think about a secondary hypertension. And essential hypertension or primary hypertension usually starts after the age of 40. So for this secondary hypertension, my mnemonic is RAD cap. RAD cap. I will write in the chat. RAD cap and others. Other causes. Okay. What is R? R is renal causes. Okay. The patient who is having like chronic kidney disease secondary to autosomal dominant polycystic kidney disease or secondary to glomerulonephritis, or renovascular diseases like renal artery stenosis in young patient with fibromuscular dysplasia and in old patient atherosclerosis. So these are the renal causes. Then E is for endocrine causes. Endocrine causes, we have the long list like Cushing syndrome, Cone syndrome, acromegaly, pheochromocytoma, thyrotoxicosis. Okay, endocrine causes. Then D is for the drugs. We have like NSAIDs can induce hypertension, OCPs can induce hypertension, steroid can induce hypertension. Then the drugs or the party drugs that can increase the chances of hypertension includes the mnemonic is ACE, ACE. A for amphetamine, C for cocaine, and E for ecstasy. Okay. The medicines that can lead to NSAIDs, OCP, and steroid. The party drugs that can lead to ACE. A for amphetamine, C for cocaine, E for ecstasy. So this is red. We covered the red. Then we have CA, that is coarctation of aorta. Coarctation of aorta. Okay. And another C is connective tissue disorders that include the SLE, systemic sclerosis, and mixed connective tissue disorders. The P is for pregnancy, pregnancy-induced hypertension like in preeclampsia and eclampsia. Other causes like vasculitis causes, vasculitis and obstructive sleep apnea. Okay, so vasculitis, which are affecting the kidneys, like small vessel vasculitis, causing glomerulonephritis and leading to hypertension, medium or large vessel vasculitis. Okay, so that can also lead to hypertension. Okay, so these are the causes. We have which one is more common, essential hypertension or the secondary hypertension? So it is the essential hypertension that is more common. Okay, and associated with the age, it is occurring more after the age of 40, and it is occurring with the obesity, it is occurring with the high salt intake, it is occurring with the increased alcohol intake, it is occurring with the positive family history. There is tip for PACES exam. Mostly the cases in PACES will be related to either endocrine causes or renal parenchymal causes or renal vascular causes or obstructive sleep apnea. So you have to focus on these endocrine causes, renal parenchymal causes, renal vascular causes, and obstructive sleep apnea. In PACES, if the patient is having hypertension, so you have to focus on these. And another tip is you have to see what investigation they have given to you. If there is electrolyte abnormality, the chances will be the patient will be having endocrine related causes of hypertension. Okay. And if the patient is having renal function problem, so it will be most likely renal causes will be there. So these are the small tips, but very effective tips. Okay, if the electrolyte imbalance is there, so the endocrine causes will be there. Okay, if the kidney functions are abnormal or the renal functions are abnormal, so either it will be the kidney problems or connective tissue disorder. So these are the another tips for the to approach the cases. Okay, in this case, you can make the differential diagnosis according to the high blood pressure, and you can make the differential diagnosis according to the obesity. Okay, but if you are making the according to the high blood pressure, so here we have to put like primary hyperaldosteronism. The second should be the secondary hyperaldosteronism. Okay, then the third should be the Cushing syndrome, and the fourth should be the Liddle syndrome. Then other you can include the pheochromocytoma also because of the headache. The acromegaly you can include, but you have to say the features are not suggestive of acromegaly and pheochromocytoma. Okay, so these are the differential diagnosis on the basis of high blood pressure in this patient. Then how you will investigate. So the baseline investigation and specific investigations. The baseline investigation here will be the complete blood count, urea and electrolyte, kidney functions, and liver function test. So here the patient is having potassium on a lower side. Potassium can be normal in 20% of the cases with Cohn syndrome. The sodium either will be normal or slightly on a higher side, while the bicarb will show the metabolic alkalosis. Bicarb also you can do. Then the specific investigation here will be the aldosterone to renin ratio. That is the key test in this case. The aldosterone will be high and the renin will be low. Okay. What about in secondary hyperaldosteronism? Both aldosterone will be high and the renin will also be high. What about in Liddle syndrome? So Liddle syndrome is rare genetic disorder in which there will be low aldosterone and low renin also. Okay, it is just opposite to Cohn syndrome. Then the next test will be like adrenal CT or MRI that will detect the adenoma or hyperplasia. Then some specific test that these are the tests related to the Cohn syndrome. Okay, specific test includes like saline suppression test. It is not the we are not discussing the Cushing now. Otherwise, Dr. Yash also include the dexamethasone suppression. That is the test for cortisol or Cushing syndrome. Okay, so here what we have to do, we have to do the saline suppression test if they are asking their specific test. So the saline solution is given IV and aldosterone production is checked. Normally, the aldosterone production is decreased or suppressed if you are giving the saline. But if the aldosterone production does not suppress, so it is in favor of Cohn syndrome. This is one specific test. And the second specific test is you have to do the adrenal vein sampling. This is the gold standard to localize the source. Okay. If they ask you what is the gold standard test, but it is not necessary that you have to do adrenal vein sampling in each and every case. There is some recommendation when to do the adrenal vein sampling and when not to do. Even if you can reach to the diagnosis that the patient is having adrenal adenoma on one side, in some cases you have to do the adrenal vein sampling even then. Okay, so these are the investigation panel for this specific patient. Then I'm going towards a management plan, and my habit is to tell the management plan according to the multidisciplinary team, then non-pharmacological management and medical treatment, and surgical treatment if it is applicable. Okay, and also for the investigation panel, and our habit is to make the investigation panel with the baseline investigation, specific investigation, confirmatory test, and sometimes the investigation to find out the complications. Okay, so going back to the multidisciplinary team here, the management plan that will include the endocrinologist, the radiologist, sometime you need the hypertension specialist, you need the GP on board. In every case, you have to include the GP on board, and you need the adrenal surgeon if it is adrenal adenoma is there. So these are the reasonable multidisciplinary team in this case. Non-pharmacological management in this patient, if the patient is a smoker, we have to inform that you have to stop smoking. Okay, low salt intake. Low salt intake. She was taking more salt, just like a sports drink she was taking as she was a sports lady in the past. We have to correlate with that also, that after taking this sports liquid or the water you are taking with the salty things, how do you feel? your fatigue or the tiredness is improving or no? So might be improving. What about your blood pressure? Did you notice that your blood pressure is increasing or no? Yes. So might be because of the high salt intake or high sodium intake, the blood pressure is increasing. Okay. Then, so the first thing is stop smoking if she is a smoker. Stop the party drugs if she is using that, or if it is the associated factor. She should take the less tea and coffee. We have to talk. Any patient who is having the palpitation, we have to make the relation with that also, and we have to inform the patient that you should cut down the energy drinks. You have to cut down the coffee and the tea and the cola drinks. Okay. Then the alcohol intake, if she's taking excessive, we have to limit that also. Then in the diet, low salt diet, but the high potassium diet. What are the diets which contain the high potassium? This will be the question in the exam. So bananas, spinach, dates, yogurt, tomato, and coconut water. So these are the 4 or 5 things that you have to remember. Okay. Then the medical treatment and surgical treatment. So here we have to give aldosterone antagonist, that is spironolactone. This is the medicine of first choice. Okay, then they will ask you what are the side effects of spironolactone. So it can cause dizziness, nausea, plus minus vomiting. It can cause gynecomastia. It can cause breast tenderness or the breast pain. It can cause tiredness, and it can lead to hyperkalemia. Okay, so what is the most common side effect of spironolactone? This could be the next question. So we have to say the breast tenderness. Okay, and the second one is the serious side effect is hyperkalemia. Okay, if the patient develops like gynecomastia or breast tenderness that is not improving or causing problem to the patient, then we have to go for the next medicine, that is the eplerenone. Eplerenone. This is this another choice, and the amiloride if the spironolactone is not tolerated. Okay, so these are the medical treatment together with the dietary advices. Okay, and if the patient is having adrenal adenoma unilateral, so we should go for keyhole surgery. We have to explain to the patient that we will do the keyhole surgery, that is known as laparoscopic adrenalectomy. Okay, we will remove the benign growth. So what could be the causes of having this cone syndrome? So now the causes, I'm just recapping. It could be the adrenal adenoma. Most common cause is adrenal adenoma. The second is bilateral adrenal hyperplasia, and rarely it is adrenal carcinoma. Okay, so these are the causes. Then according to the cause, we have to decide the surgical treatment also and the medical treatment also. If it is adrenal adenoma, unilateral, most common cause. So if we are doing the adrenalectomy, it can be the curative surgery for the patient. But if it is bilateral adrenal hyperplasia, we have to go for medical treatment. If it is adrenal carcinoma, if it is diagnosed at an earlier stage, we should do the surgery. Otherwise, mostly the patients are coming at the late age or when the tumor is spread out. So mostly the patient will need the palliative care in adrenal carcinoma. What could be the complications of Cone syndrome? So the complications of Cone syndrome will be related to the hypertension and will be related to the hypokalemia. This can be like refractory hypertension. In this patient, she is having refractory hypertension, and this can lead to hypertension related emergencies or urgencies. It can lead to increased risk of ischemic heart disease, increased risk of stroke, increased risk of renal failure, hypertension related. And hypokalemia can lead to arrhythmia and muscle paralysis or muscle weakness. Okay. So this is about the this case complete package. I'll try to see the possible. Okay. As I told to you people that time is limited for me today. So I will send the doctor who is asking about the red cap. I will send you in my group. Dr. Iman, I think you are. So I will send you in my WhatsApp group. Okay, so thank you very much for being with us today. If you have any questions, you can write in the chat of our WhatsApp group. Okay, and if you want to join our WhatsApp group, this is the barcode you can use, or you can send me message on this number.
Thank you, sir.
Thank you so much, Dr. Yash. OCPs are contraindicated if the patient is having high blood pressure. Especially, that is also the point of discussion when to stop the OCPs. Okay, so a lot of discussion can be done here, but I'm sorry for the short period of time for me today. See you on the next session, most likely after 1 week. Have a good day. I will end the meeting. Thank you so much. Good night.